Hello, my dear friends, colleagues, ladies and gentlemen. Good morning or good evening. I am Dr. Murlidhar Kanchi, Dean of Indian College of Anaesthesiologists, speaking to you from Narayana Hrudayalaya, Bangalore in India. It's an absolute pleasure for me to invite you for this meeting, which is ICASA, which is ICA ASA meeting. I am grateful to the Indian College of Anaesthesiologists, that is the ICA, and ASA for this opportunity. This is a wonderful opportunity to come together. And as you know, 174 years ago, in 1846, the same day, ether was administered successfully for a surgical procedure, and anesthesia is not a humbug. What a great day to get together virtually. I would like to introduce and call upon Dr. Radhakrishnan to take over the proceedings. Radhakrishnan, as you are aware, he is a leading figure in the National Fraternity of Anesthesiology in India, and he has held several important positions in the past, which included the president of Indian Society of Anesthesiologists, the biggest anesthesiologist organization in this country. And now he is a big leader in the Indian College of Anaesthesiologists. And we meet every Wednesday to conduct webinars, and he is leading the way for us to do that. With that words, I would like to invite Dr. Radhakrishnan to take over and start the proceedings. Dr. Radhakrishnan, please.
Thank you, Murali. Good evening, all, my seniors and my colleagues, wherever you are. Today is a commemoration date on which either vapor was used clinically to produce a painless state so that surgery without pain could be conducted. And we anesthesiologists all over the world was celebrating this date as the either day, and now we moved out to name it as World Anesthesia Day, and we continue to do our celebrations. Indian College of Anaesthesiologists brings you remembrance of the day and wish you all bright days ahead. This year's Anesthesia Day is special. We were lucky to have with us Dr. Beverly Phillip, current president of the American Society of Anaesthesiologists. Good morning, madam. Welcome to Indian College. Our deans, on their initiations, was able to tie up with the ASA and run this webinar as ICA ASA joint webinar on inhalation anesthesia. I salute my colleagues, Dr. Girish Joshi, Dr. Baljeet Singh, Dr. Muralidhar, and our Chief Trustee, Dr. B.P. Kumra, in promoting the activities for this webinar. This particular webinar on inhalation anesthesia is going to be dealt under 4 different heads. And the speakers joining are Dr. James Phillip and Dr. Girish Joshi from ASA, and Dr. Sengupta and Dr. Ashish from ICA. I welcome the speakers to this particular function. Friends, we are all troubled by the pandemic. Coronavirus is almost dancing around us. In spite of the diverse ethical, moral, social diversities going on in this large country, we are all, with all the world citizens, in trying to combat the disease. But our efforts are not reaching anywhere. We hope we may be able to get substantial cure very soon with a definite plan of management, and probably the arrival of a vaccine is at the horizon. Probably within 3 to 6 months time, we may be able to be blessed with a vaccine and we could arrest the disease. Okay, that's our hope. As you all know, October 16, 1846, Mr. W.T.G. Morton demonstrated the public for the first time that painless surgery could be produced, and he used the ether vapor. And in fact, Mr. Morton was not the discoverer of anesthesia, but Morton definitely, owning inspiration and through his dedication, was able to demonstrate that a particular drug could be used to produce painless state of mind so that anesthesia could be tried. And a era was born, and we today say anesthetic era was born in 1846. And looking back, I may say this is the third wonder or third greatest event in the modern medicine today. Anyway, our growth in the first 100 years was slow, sluggish, and shrouded in mystery, as you all know. But in the last 70 years, we climbed heights with the help of smart medicine, smart drugs, latest techniques, and skillful and effective monitors and standardized safety protocols. And we are achieving. We are achieving what we wanted in the past. And today we are heading towards bringing up a science which is unparalleled in its achievements. We hope we may be able to go to further heights very soon in the next 2 decades with advancements. I wrap up my introductory remarks thanking once again the ASA President Dr. Beverly Philip, speakers Dr. James Philip and Dr. Girish for joining us in this venture, and hope we could have similar ventures quite often as we go ahead. And finally, before I leave, I thank the American Society of Anaesthesiologists and the President and the ASA members in putting up the best ever seen virtual International Anesthesia Conference, which was conducted last week. And you proved to the world that a virtual conference, good in quality as well as in comfort, could be achieved by sitting in the room. Keep up your efforts. Thank you once again, and wish you a lively webinar.
Thank you, President Radhakrishnan. Can you see my screen?
Yes.
I will now take the pleasure of introducing ASA President Dr. Beverly Philip, who was kind enough to present today and also was present last year at the ASA meeting when the affiliation agreement between the Indian College of Anaesthesiologists and the American Society of Anaesthesiologists was conducted. And thanks to the ICA for appointing me as the Honorary International Dean for the Indian College of Anaesthesiologists. And this is indeed our first joint webinar with the ASA, and how nice that it can be done on the World Anesthesia Day. And we are so glad to have today Dr. Beverly Philip, whom I've known for many, many years. She is the president of the American Society of Anesthesiologists and is currently professor of anesthesia at Harvard University. She was the founding director of the day surgery unit at Brigham and Women's Hospital, Boston, and the immediate past president of the International Association for ambulatory surgery. Dr. Philip's subspecialty and research focus has been ambulatory anesthesia, and she was once president of the Society for Ambulatory Anesthesia. And she has a related interest in anesthesiology policy, particularly quality, which is so important these days, and regulatory issues with federal and accrediting organizations. Welcome, Dr. Beverly Phillip. We now have you say us a few words at this first collaborative webinar that we are conducting on such a wonderful day. Welcome.
Thank you very much. What I want to give my special honor and regards to the Indian College. It is a great occasion for us to be able to share this together. There we go. Of course, I'm giving you greetings from Boston, where the first public demonstration of ether was, and also from the American Society of Anesthesiologists. And this is indeed both our past and our future. And I want to give you some thoughts about where, at least from the ASA perspective, where the future looks to us. This year, we spoke, of course, about COVID, but that is now going to become part of our environment. As organizations, for the Indian College and for the ASA, we have to look forward. And this is one of the years that we do strategic planning, and we took a whole new look at what we want to do. As at the top of our priority list is going to be research and discovery, because this is what makes us a physician specialty. And we are going to have an emphasis on fostering research at all levels, from basic to translational to clinical sciences. And we want to advance knowledge in anesthesiology as broadly as possible, share that information widely, and especially in these tight economic times, make sure that we are supporting our researchers as a community. The next thing that every organization has to be concerned about is member engagement. And this is another major priority for us, and I am sure for you as well. Developing value propositions to keep members engaged and get new ones. We are especially looking to focus on residents, and the other difficult time is the transition to practice, from residency to be practice. And as the college represents India broadly, in the US as well, we want to especially reach out to support our component societies, our subspecialty organizations, and our charitable foundations. Other focuses of energy that we need to do to move into the future are working on education for all range of what our members need throughout their career. As you know, thank you for the compliments about our recent virtual annual meeting. It was really a marvelous experience to have to pivot and develop it, and it was very exciting to participate in as both helping to sort of launch it, and really even more so as a student of the meeting as well. Two other points I want to mention about where I think our future goes, and the ASA and the ICA in parallel. We need to work on leadership and professional development. We really have to build out our members to develop leadership skills in your organization, in their practices, and in the healthcare system. We need the physician voice in the healthcare system. So what we're doing on the ASA side is developing education, formal education in leadership and practice management for everybody, residents to experienced, beginner to expert. And the one last point I want to make is about, as you said, quality is number one. So we're going to be working on quality advancement. We need outcome measures, good practice guidelines, and we need outcomes research so we know what we're doing and we know how to make it better. So with that, I would like to wrap up. I wish the Indian College of Anaesthesiologists and also all the members listening, all the anesthesiologists in India, the very best for an exciting future, and all of us in the world on Anesthesia Day in partnership going forward. Thank you.
Thank you, Dr. Beverly Phillip. Thank you for those wonderful, encouraging words. And
You're welcome. Thank you.
thank you. Can you hear me now? Thank you, Dr. Beverly Phillip. That was such an encouraging talk for all of us. And I'm sure that many young Indian physician anesthesiologists would like to take leadership roles and will participate in the future with the ASA for those courses that are being offered. And we can certainly work something out for them. So we thank you again for those encouraging words. We will now go on to the program, and let me share my screen. Do you see my screen now?
Yes, we can.
Yes, we can.
So it's my pleasure to introduce the first speaker, Dr. James Phillip, who happens to be the significant other of our president of our Society of Anesthesia in the United States. He is an anesthesiologist at Mass General Brigham Hospital and professor of anesthesia at Harvard Medical School. Educated initially as an engineer, so no wonder he's such an expert on inhalational agents, particularly the SIM-Man that he has developed. And he's also a very credentialed clinical anesthesiologist. He spent his career providing ambulatory anesthesia, clinical care, and creating 6 successful medical products because of his engineering background, I'm sure. He's also created a nonprofit educational tool that I referred to earlier called GasMan. It is for learners, teachers, researchers, and clinicians to master the kinetics of inhaled anesthetics. Today, he will explore the kinetic evolution from ether to xenon, and it's so wonderful to have you with us, James. Couldn't be a better person for this talk.
Hello, I'm going to speak about the evolution of drug solubility and kinetics from ether to xenon. Blood gas partition coefficients are the key to understanding the differences among our inhaled anesthetics. The blood gas partition coefficient, lambda sub blood gas, also called the blood gas solubility ratio, the blood gas solubility, just plain solubility, and abbreviated this way. All of them are the same, and I will use them interchangeably as often as done. When we look at the partition coefficients or solubilities of our drugs from 1846, when the introduction of ether, all the way to very recent years of modern anesthetics and xenon possibly coming in the future, we see a solubility range that's quite large. We see that ether at solubility of 12 is 92 times more soluble than xenon, and it's 28 times more soluble than desflurane, an incredibly wide range of blood gas solubility. So what does blood gas solubility really do? Why is it important? Blood gas solubility determines how closely the expired tension approaches the inspired tension. How closely, not how fast. This isn't a speed thing. This is a closeness thing that may appear to change the speed of the anesthetic, but that's not what's really happening. We can see this by viewing the alveolar tension curve. I use the word tension here. Tension is partial pressure expressed in percent of one atmosphere. It's equal to the concentration of gases, but once gases get into the blood, partial pressure is a better term that's actually correct. The alveolar tension curve is the alveolar response to an inspired step. It's equal to the time course of the alveolar tension in response to the step change in the inspired tension. Let's look at that. We now have the step change in inspired in the yellow, And we're going to look at pure lung wash-in without uptake into blood. This is just drug going into the patient's lungs, and we're going to look at the alveolar response to this step change. Here we have the curve. The curve goes up rapidly at the beginning and then more slowly. This is the alveolar response to a step change, and it's an exponential curve. This exponential curve has only one characteristic, and that is its time constant, the amount of time it takes to get 63% of the way to its final value. In this case, it's 1/2 minute. That 1/2 minute comes from the physics and physiology of this. The time constant for any fully mixed system is the volume of the compartment divided by the flow going through that compartment. In this case, that volume is the FRC divided by the alveolar ventilation, or 2 liters divided by 4 liters per minute, or 1/2 minute. And that's where the lung wash-in time of 1/2 minute comes from. And it's why we typically wait 2 minutes for things to happen, allowing 4 time constants to go along to get expired closer to the inspired anytime we are doing anything. Now let's take uptake into blood. Uptake into the blood produces an alveolar tension plateau. That is, as inspired goes up suddenly, alveolar was rising, that curve breaks off at a level dependent upon how rapidly drug is being taken away in the cardiac output, which has with the solubility of the anesthetic agent. So for drugs of high solubility like ether, this keeps us incredibly low. For drugs of low solubility like our current isoflurane, sevoflurane, and desflurane, we see it's much, much higher. And for Xenon, of course, still higher. So the alveolar plateau height is measurable, and it can be measured for each of these agents. And in fact, it's 100% predictable. It's predictable in that it's 1 divided by 1 plus cardiac output times solubility divided by alveolar ventilation. This is the equation that defines the actual plateau height for each of our drugs. So each of them for a different solubility, of course, has a different height, as one would expect. Now, venous return, this return converts this plateau into what we call the knee and the tail of the alveolar tension curve. This is when drug is brought back from the venous blood to the patient's lungs to be circulated again out in the arterial blood, and that's the tail of this curve. If we look at all of our drugs, they are really quite similar. If we look at the overlay now of the alveolar inspired ratio in drugs from ether to xenon, we see the same characteristic curve. They all start out on that same exponential curve and break off at levels dependent upon the solubility of the drug in blood. Now, the danger of high solubility is that increased minute ventilation deepens the anesthetic and produces an anesthetic overdose. And that's why the inhaled drug evolution is focused on producing drugs with reduced solubility in blood. Drugs with high solubility become, or actually are, more dangerous whenever ventilation is increased. Now, many of us practiced in the era of halothane. It was a wonderful drug for inhalation induction in children, but now and then a patient didn't survive the process. And usually it had something to do with hyperventilation at a time that wasn't expected. Let's look at a simulation of exactly that happening. Here we have in the red, so we're looking at the anesthetic partial pressure in the patient's alveoli, which is very close to that which is in the patient's brain. We see in the natural course of things when ventilation is constant, inspired is going up, expired is now coming up, and with decreased ventilation that happens naturally with halothane, we get the patient remaining at a fairly reasonable anesthetic depth. If we are ventilating the patient, however, the patient is getting deeper than that. And if we're hyperventilating the patient is getting incredibly deeper than that, leading to a significant toxicity, manifest by decreased heart rate and blood pressure and all the other things that we don't see anymore in pediatric inductions now that we've abandoned that drug in most countries. We can look at something just like this and what would happen with ether. I'm going to play a simulation. Here we see two simulations about to be run. We have ether at the top and sevoflurane at the bottom. We're going to begin that anesthetic by hitting run all. And we're going to see the anesthetic levels come up to the 1 MAC level in the vessel ridge group in ether. And we get it there also in sevoflurane. Sevoflurane had a little bit of overshoot in the alveolar concentration. Ether did not. We can see that on these two curves as well. At this point, I'm turning down the vaporizer to a more reasonable value and continuing the simulation. So with the vaporizer setting lower than it was before, we've got the patient at a constant depth of anesthesia. And notice the large gap between the inspired or vaporizer concentration and the alveolar concentration for ether, because it is so very soluble. Now, at this point, we ask ourselves the question, is there any danger of this high solubility? Is there any danger with having the inspired concentration so high compared to the expired concentration? The answer is, let's see what happens if we hyperventilate both of these patients in the middle of the anesthetic. I shall do that now. So the ventilation has gone up. The ventilation has gone up. The expired concentration of ether is going up dramatically, whereas for sevoflurane, it's remaining almost exactly constant. Any insoluble drug will have this property, and any soluble drug will have that property. If we look at the overlay, show alveolar over MAC, we see that in the case of ether, alveolar gets much, much above MAC, probably enough to cause some cardiovascular problems. Whereas with a less soluble drug, we get a very constant level in the alveolar compartment and in the vessel ridge group. So we've achieved much greater safety as we've evolved from drugs of high solubility to drugs of much, much lower solubility. From ether to isoflurane to sevoflurane to someday Xenon, we really have a dramatic improvement in this particular property of these drugs. Thank you.
Thank you, Dr. Philip. That was an excellent overview from the day we started using inhaled anesthetics. And by the way, both Drs. Beverly Philip and James Philip are in Boston, where the first ether demonstration was done at the Ether Dome, which is so popular. So now we move on. And by the way, for those who have questions, please send those through the chat function, and we will look at those questions when we come at the end of the presentations. I now request Dr. Muralidhar to introduce the next key speaker, Dr. Sengupta. I will stop sharing my screen.
Yes.
And you can go ahead and introduce Dr. Sengupta.
This is Muralidhar speaking to you. I take great pleasure in inviting Saikat Sengupta, who is a close friend of me from Calcutta. He is a senior consultant and academic coordinator in Apollo Gleneagles Hospital, Kolkata. He has many achievements. I don't think I'll be going through it because it'll take the time. And he has published widely, both in international and national journals. And he's very acclaimed speaker and sought after speaker and presenter in many meetings. With these few words, I would like to welcome Saikat Sengupta to talk on what happens to the heart with inhalational agents. Dr. Saikat Sengupta, please.
Thank you, sir, and good morning and good evening as it would be appropriate. And I would thank the Indian College of Anaesthesiologists, Dr. Radhakrishnan, Dr. Belani, as well as the American Society of Anesthesiologists to give me an opportunity to speak about myocardial preservation and preconditioning with inhalation agents. I bring greetings from my hospital, Apollo Gleneagles in Kolkata, India. No conflicts of interest to be declared. And what I would possibly do over the next 20 minutes is essentially go through a review of literature, which I have tried to chronicle historically. If you look at research since the 1970s, mid-70s in anesthesia, people have tried to figure out whether there is an exploration of the potential beneficial effects of anesthetic agents other than what they are supposed to do, that is put people to sleep, and more specifically, the volatile anesthetic agents on the ischemic myocardium. About inhalation agents and the ischemic myocardium, it was not necessarily about the direct effects on the myocardial oxygen supply balance, neither on the coronary vasculature. What people realized and were enthused about was the property of these volatile anesthetic agents to mimic the intrinsic cardioprotective mechanism of ischemic preconditioning. I'll take you back to 1986, and this is the time when Elie Wiesel was given the Nobel Prize. Out of Africa won a lot of Oscars, as well as the world saw the disaster of Challenger and Chernobyl. At the same time, Dr. Murray was clamping and ligating the lateral circumflex artery of dogs. And his research, looking into the multiple brief ischemic episodes protecting the heart from a subsequent sustained ischemic insult, heralded an era of intense research trying to identify the underlying mechanisms and explore the potential clinical implications. The focus was also on the pharmacological modulation of the phenomena of the anesthetic preconditioning of volatile anesthetic agents. And it brought in a plethora of preclinical experimental results and publications relating to the volatile anesthetic agents with its ischemic reperfusion injury and inflammation. A kind of mechanism on how it works to protect the myocardium, whether it is through the risk pathway or the safe pathway, was postulated, essentially boiling down to modulation of G protein coupled receptors, this risk pathway, the gene expression, and the intracellular signaling pathways, all kind of trying to figure out how good they were in opening the ATP-dependent potassium channels in the mitochondria and the sarcolemma to improve the mitochondrial function of the myocardium. Trying to figure out whether an ischemic insult or a reperfusion injury, did it create a reduced infarct size than what it was supposed to? Did it have a better function after they were conditioned with an anesthetic volatile agent than they would be if it was not? It also then accumulated a lot of clinical data on the cardioprotective effects of the volatile anesthetic agents in patients undergoing, specifically on-pump coronary artery bypass grafting. With this ultimate goal, trying to see whether experimental physiology research actually translates into better strategies to improve the outcome of our patients. And do these cardioprotective effects of volatile anesthetic agents against the consequences of ischemia reperfusion injury convincingly observed in experimental research can translate into improved perioperative outcomes. So with the beginning of the 21st century and the advent of Google into our lives, the GPS into our lives, despite the bad happenings of the tsunami and the 9/11, the anesthetic scientific community was enthused by this. And a lovely editorial appeared in the Anesthesiology in the year 2002 by Dr. Todd. And it was kind of a serendipity. And he says that the economic pressures led to a relatively greater use of volatile anesthetic agents in cardiac surgery. And it was also observed that there was a reduced frequency of ischemic events, maybe because they had certain cardioprotective effects or properties. And this not necessarily was because of simple alterations in the myocardial oxygen supply and demand. there was something more about this cardioprotective effects, and it was akin to the ischemic preconditioning that is seen, and the same kind of signal transduction elements could be seen with these agents. The results to date demonstrate that yes, anesthetic preconditioning was there. This is in 2002, and he called for larger trials, getting in more patients from more centers to look into the hard clinical outcomes of morbidity and mortality and the impact of anesthetic preconditioning in cardiac and non-cardiac surgery. And did they not come? They came. And one of the leaders to this was Stephen de Hart from Antwerp. And they looked into whether sevoflurane preserves myocardial function in coronary surgical patients. And they found that yes, if you look at by the DPDT pre and post the bypass, it was found that it was much better in the sevoflurane group than in the propofol group. And if you look at the cardiac biomarkers like troponin, it was much lower in the sevoflurane group than in the propofol group. They got a little braver, and they then looked into the effect on myocardial function in elderly high-risk patients. And they kind of observed a very similar kind of trend. The people who received volatiles did better with myocardial function. The recovery index was much better of the preservation of left ventricular function after a CPB was more in the sevoflurane group, and there was less evidence of myocardial damage post-operatively. Did this cardioprotective effects of sevoflurane also was related to the modalities of administration? Did it matter if it was given just before bypass or after bypass or through the entire procedure? What did they find? Again, with myocardial preservation or the function, it was better with the volatile group and the best when sevoflurane was given through the entire procedure. If you look at the cardiac biomarkers, they're lesser in the volatile group than in the propofol group, and where they're the best is when sevoflurane was given through the entire bit of the procedure. So in the middle of that decade, Stevie de Hart in an editorial says that yes, there are results which are positive, but still the results in clinical outcomes are very, very, very variable. And though there is this biochemical and functional variables which are better in the volatile groups, we still don't know whether it translates to better clinical outcomes. And we know about it in on-pump CABG. We are still not sure whether the same would translate to valvular cardiac surgery or in non-cardiac surgery, the outcomes. The real deal, as they figured out and the world tried to know, was does it matter about the ICU length of stay? Does it matter about the hospital length of stay? Does it matter about morbidity like MI and mortality? Publications came out. Some of them looking into this with vis-a-vis volatile versus TIVA were not so good. I would bring your attention to two meta-analyses that came around that time. And this one is from Australia, looking at off-pump and on-pump surgery, comparing non-volatile and anesthetic intravenous agents, looking at several outcome measures, myocardial function, cardiac biomarkers, and hard clinical outcomes. And what did they find? They found that yes, troponin I levels, cardiac index, even ventilation time and hospital length of stay possibly favored the volatile group. But there was no significant difference in myocardial ischemia, MI, and hospital mortality between the two groups in their meta-analysis. A year later, the San Rafael group published another meta-analysis trying to figure out whether the cardioprotective effects of volatile agents actually translate into decreased morbidity and mortality in patients undergoing cardiac surgery. And what did they find? That this is where, that even with MI, it possibly favored the halogenated group. The NNT was around 37 with a relative risk reduction of 53%. Even with mortality in their meta-analysis, they found that the NNT was 84 with a relative risk reduction of 75%. The Wackman group also looked into this in 2009, and they were looking not only at cardiac biomarkers, but at one-year mortality as well. And they found that yes, it was known, the biomarkers were lower in the sevoflurane and desflurane group, But here they also find that there is a change with mortality percentages, and the patients who were given intravenous fared worse. 2016, again, the San Rafael group looking into propofol versus Treva, and their primary outcomes being looking at hospital length of stay. The secondary outcomes looked into mortality. And what did they find? Yes, cardiac biomarkers were definitely lower in the volatile group. Hospital length of stay as well, lesser in the volatile anesthetic group. But with 1 year mortality, there was no significant difference whether they received propofol or no propofol, whether they received sevoflurane or no sevoflurane. So when we come to the next decade with the Arab Springs revolution, with a Jesuit Pope becoming the Pope, and 2 neighboring countries sharing the Nobel Prize, we have come to this state that in a patient subset of those undergoing on-pump CABG, and when you're comparing volatile anesthetics to intravenous anesthetics, and if you're looking at cardioprotective actions, typically from ventricular functions, whether it is DPDT or R, are the cardiac markers, trials, multiple systematic reviews, and meta-analysis would possibly say that the volatile groups were faring better. And the question was asked, have you reached enough data to say that we don't want any more research into this? And this trial sequential analysis published in 2016 actually tried to demonstrate that clinical studies investigating the cardioprotective action of volatile anesthetics on cardiac troponins in CABGs are no longer required. Is it the same? Is it true for even off-pump surgery? That is what they were trying to look at. And they were also trying to figure out whether the required information size was reached and the futility boundaries have already been reached. What did they find out? Yes, about troponin in on-pump CABG, it definitely favors the volatile group. No questions on that. What about off-pump surgery? What about mid-caps? The meta-analysis did not reach a statistically significant level, favoring either the non-volatile or the volatile anesthetic group with respect to post-operative cardiac troponin I serum levels. The required information size, as per this publication in 2016, says that it was reached already in 2006. And therefore, further investigation on these questions appears unnecessary because that numbers have been already reached. And this is only about cardiac biomarkers, myocardial function, not about hard clinical outcomes. The same cannot be said about off-pump CABG. The required information size was yet to be reached. So there possibly is a case, even today, about looking into the volatile anesthetic groups, whether they're doing any better in those undergoing off-pump cardiac surgery. I now bring again this invited commentary from Stephen D. Hurt in 2016 in context. 2002, Michael Todd says that yes, we accept that there could be something happening with volatile, but we need hard clinical data about morbidity and mortality. 2005, Stephen D. Hurt again says, yes, biomarkers are better, myocardial functions are better, we still don't know about hard clinical data. 2016, he accepts that the effects of volatile anesthetics on myocardial biomarker released have been well established. The clinical implications even then are less obvious. The effects on hard endpoints such as morbidity and mortality remain to be established. The incidence of these endpoints is accepted in modern anesthesia, and surgery is low to be addressed in small studies, and the call is for large multicenter trials. The specific protective properties of volatile anesthetics are only applicable in the presence of perioperative ischemia reperfusion injury, and therefore it is possibly pointless trying to address this question in a patient population where this occurs rarely or not at all. To put this clinical thing into perspective, this got published in March 2019, led by Giovanni Landoni, the Myriad Study Group, in the New England Journal, a pragmatic multi-center single-blind controlled trial across 36 centers in 13 countries, undergoing CABG either through the volatile anesthetic techniques or TIVA, with the primary outcome of any cause death at 1 year. They initially thought they would recruit 10,000 plus patients, but a midterm analysis, they were asked not to recruit any more data because what was being seen was there was hardly any difference. The Kaplan-Meier curves are kind of overlapping on one another, sevoflurane versus the halogenated versus intravenous, no difference. Neither in secondary outcome data like death from cardiac causes at 30 days, non-fatal or fatal MI, or even the hospital length of stay. Which brings into now the question, what about valve surgeries? What about non-cardiac surgeries? If you read through editorials from 2000, the early 2000s to today, the search is for the magic bullet, is whether this works in non-cardiac surgery. I just picked up a couple of publications on non-cardiac surgery, looking at myocardial ischemia and MI, looking at continuous ECG and trop elevation and additional endpoints like cardio biomarkers. You find that there is hardly any difference between the two groups in non-cardiac surgery, and also about secondary endpoints about cardiac biomarkers as well. Non-cardiac surgery, thoracic surgery, does it change the major complications early, during hospitalization, or even after 6 months? If you look at this, it says that there is no difference between the two groups. So what are we, or where are we today? The great expectations that we once had with regard to the potential clinical implications of myocardial anesthetic preconditioning possibly have not been reached, especially with vis-a-vis hard clinical data. There could be multiple reasons which explains this discrepancy. Factors such as non-uniform extent of the ischemic insult. It's not always the same in the perioperative period. Comorbidities like diabetes, concurrent medications like sulfonylureas, beta blockers may be kind of blurring the data. And what it teaches us is there is a huge gap between well-controlled lab experiments and the complexity of each individual patient that we have to treat. And I'll take you again back to 1989 and look at the concluding remarks of Slogoff and Keats in their publication on randomized trial of primary anesthetic agents on coronary artery bypass operations. And they said that despite differences in the hemodynamic consequences of various anesthetics used, none of these significantly influenced outcome. Instead, the primary role of the anesthesiologist in the management of these patients appeared to be the control of hemodynamic stability. So is the take-home message that yes, we do understand that there is the cardioprotective action of inhalation agents. However, perioperative outcome of our patient does not depend on the agent we are using. Is it more so about our capability on how we use the available tool and the anesthetic techniques to control, especially in cardiac and non-cardiac surgery, the hemodynamic homeostasis of our patients? Thank you once again for this lovely opportunity. I'll stop sharing and hand you over to Dr. Kumar.
Thank you, Dr. Sengupta, for addressing this reasonably controversial issue. And I'm sure many clinicians are looking, like you said, for that magic bullet, right? So we will talk about that during the question and answer session. I now invite Dr. Baljit Singh to introduce our next speaker. And meanwhile, if we can have the speaker share the slides and put up the first slide while Dr. Baljit Singh introduces the speaker.
Good evening and good morning to overseas friends. Well, I have tremendous pleasure introducing Dr. Ashish Bindra. She is additional professor of neuroanesthesiology and critical care at Neurosciences Center and Jayaprakash Narayan Apex Trauma Center, All India Institute of Medical Sciences. Her research area mainly is neuroanesthesia, target temperature management in traumatic brain injury, cerebral microdialysis, and epilepsy anesthesia. And she has a number of publications in the area of her specific interest, that is epilepsy surgery. She has a large number of publications, most of them international, and she has 5 chapters in various books, and she's on the editorial board of Neurology India as well as the Journal of Neuroanesthesiology and Critical Care. She's an erudite speaker, and it's a delight to listen to her. I've had the privilege to listen to her in the postgraduate assemblies that I used to organize on behalf of Indian College of Anaesthesiologists at G.V. Pant Institute. And I think I'll pull myself out between her and the audience. She'll be speaking on effects of inhalation agents on cerebral pathophysiology. Dr. Bindra, the floor is yours.
Thank you so much for this kind introduction and the opportunity to present on this forum, which is first kind of webinar, as I understand, between ASA and ICA collaboration. And the topic assigned to me is the effect of inhalational agents on cerebral pathophysiology. So cerebral physiology as such is the brain is highly demanding organ, and it requires constant blood flow, and the cerebral metabolic oxygen rate consumption is as very high for this, and it closely competes with the heart for its metabolic requirements. And it has an internal mechanisms like cerebral autoregulation, flow, metabolism, coupling, and vasomotor reactivity, which provides these energy substrate to the brain and keep its internal milieu stable. So when there is a disease or when there is a drug which affects the central nervous system, there is a tendency of wobbling of this normal homeostasis towards an insult or injury. So it can be a space occupying lesion, which can result in the intracranial pressure rise, or it can be because of the spasm associated with the aneurysm, which can decrease the cerebral blood flow, or it can be a seizure, which can increase the cerebral metabolic rate. And then the cerebral pathophysiology, when these patients are anesthetized, or what is the effect of these anesthetic and adjuvant drugs on these metabolic parameters, and the fine balance which was maintained. If it trips on another side, then it may lead to brain hypoxia or hernia, and this is what we don't want. So in this talk, we are talking about the effect of the anesthetic agents and as well as the disease. We will talk about the physiology first, and then we'll go to the clinical scenarios when we can see how in clinical practice these agents are going to, or they affect the practice of neuroanesthesia. So if this is a standard table which you encounter whenever you open a standard good text of neuroanesthesia, wherein we can see a wide demarcation between the inhalational anesthetics and the intravenous anesthetics and their effect on the cerebral metabolism and cerebral physiology. So it is mainly the inhalational anesthetic agents are different from the IV anesthetic agents in the fact that the halogenated inhalational agents, including isoCO and desflurane, they tend to increase the cerebral blood flow. So basically they are vasodilators. In that fact, they may increase the intracranial pressure. However, they are very good suppressant of the cerebral metabolic oxygen rate consumption. And also they have a favorable or slightly unfavorable effect on cerebral physiology, that is the cerebral perfusion pressure, which can be documented in animal studies and less commonly documented in the clinical studies. And the other non-halogenated inhalational anesthetics, especially the nitrous oxide, which has a controversial role in neuroanesthesia because it increases the ICP and the cerebral perfusion pressure is grossly reduced. And the cerebral blood flow, it increases. Xenon is the newer non-halogenated inhalational anesthetic, and it is more or less projected as an ideal anesthetic agent because this agent is not associated with increase in cerebral blood flow. Neither it is causing a rise in ICP, and it is also decreasing the cerebral metabolic rate for oxygen consumption. As contrast to their counterparts, the intravenous agents, they are known for decreasing the cerebral blood flow and also decreasing the intracranial pressure. So this is the main difference between the effect of these two classes, that is the intravenous versus inhalational anesthetic on the cerebral physiology. So let us work further. So just to see that the brain has a constant supply of blood, that is 50 ml per 100 gram of the brain. And similarly, the cerebral metabolic oxygen consumption is fixed in normal conditions. However, whenever we give drugs, especially either the TIVAs or the inhalational agents, they cause the metabolic suppression. But the metabolic suppression is maximum when they achieve the isoelectric EEG, which is usually at 1.5 to 2 Mach of the inhalational agents. Beyond that, the cerebral metabolic rate for oxygen consumption is not decreased. However, these agents keep to increase the cerebral blood flow. So metabolism is decreased, but cerebral blood flow is increased, which may lead to luxury perfusion. And it is specifically in pathological conditions wherein they can have a vasodilatation in the non-diseased brain, whereas in the diseased brain, it may lead to vasoconstriction because the autoregulation may not be working very well. So the hyperemia may be caused by these agents. This is another concern which is postulated with the use of these anesthetic agents. As we can say that these fluorinated, if we talk of fluorinated ones, they have the rate of increase in the cerebral blood flow is highest for halothane, and it is minimum for sevoflurane. However, the cerebral metabolic rate for oxygen consumption is suppressed almost equally by all the volatile and anesthetic agents. However, say halothane is slightly less for the halothane. So going with this much of background, let us see how the metabolic rate or the consumptions are regulated. So inside the brain, we have a variety of mechanisms which are set in place so as to maintain a constant blood pressure or cerebral perfusion pressure. So we have cerebral autoregulation, the vasomotor reactivity, and neurovascular coupling, which play a role by neurogenic and myogenic influences, and they change the vascular diameter so as to respond to the changes in the requirement of blood to particular area. However, with when we say that cerebral autoregulation, people say that it is almost always maintained with TIVA or the intravenous agents, whereas the volatile agents, they tend to alter or they tend to decrease the cerebral autoregulation at doses which are higher than the clinical doses. That is around 1.5 Mach for isoflurane and desflurane, and greater than 1 Mach for sevoflurane. Similarly, the vasomotor reactivity, which tends to be lost with higher doses of volatile anesthetic agents. So this is the curve for cerebral autoregulation. The cerebral autoregulation, this curve states that between a pressure of 50 to 150 millimeters of mercury, there is a constant supply of perfusion. The perfusion pressure remains the same, but beyond that limit, the cerebral blood flow perfusion becomes pressure passive. That is, if you increase the blood pressure beyond 150, you are likely to end up in hyperemia. And if you decrease the pressure below 50, you're going to land up in hypoxia or the ischemia. So when we talk about the effect of the disease and the drug on the cerebral autoregulation curve, so this curve is going to tell us that with injury in the brain or with the use of the anesthetic agents or this cerebral autoregulation curve is preserved. However, the range becomes quite narrow. That means the brain is less able to tolerate the rise in the blood pressure and also the decrease in the blood pressure. That means that in a hypertensive patient or a ischemic injury patient or patient with higher doses of the volatile anesthetic agents, possibly you need to maintain the blood pressure in a narrow range so as to supply adequate perfusion to the brain. So if we look, this is a paper from Anesthesiology 1995, wherein the authors studied the role of the cerebral autoregulation, wherein the 3 doses of anesthetic agents were used, where propofol was used in low dose, that is 100 mics per kg per minute, and desflurane and isoflurane 0.5 Mach. They tend to decrease both dynamic and static cerebral autoregulation. However, at these low doses, these depressions were not that very severe, and the autoregulation was more or less preserved, but it was slightly lesser than the propofol group. And whereas at higher concentrations, like greater than 200 mics for propofol and 1.5 max for the isoflurane, desflurane, these appear to be suppressed, and more so, even for the static autoregulation, wherein it was slightly preserved better, but grossly you can say with the higher levels of the anesthetic agents, these were impaired, the autoregulation was impaired. So next is the effect of anesthetic agents and the disease on the CO2 reactivity. So one good thing about it is that at clinical levels of anesthesia, the cerebrovascular responses to alteration in CO2 are well preserved. And though the magnitude of the response may vary according to the agent and anesthetic depth. So this is the reason that even with high concentration of the volatile agents, if you produce hyperventilation, that is hypocapnia, the likely increase in the cerebral blood flow is likely to be neutralized with hypercapnia. So with hypocapnia and volatile anesthetic, if you feel like using in higher doses, the effect is almost balanced. So this is good thing about the use of volatiles, that CO2 reactivity is preserved and the brain swelling can be controlled by controlling the cerebral by hyperventilation. Though the hypocardia was well studied, this is a new study which compared the effect of, which compared the reactivity to hypercapnia during sevoflurane and desflurane anesthesia in rats, wherein people believe that desflurane should cause more of vasodilation and more increase in ICP. But here in this study, in this experimental model, it was seen that the sevoflurane and desflurane, they reacted to hypercarbia as well by dilatation of the bile vessels. Now, next is the flow metabolism coupling. So this flow metabolism coupling means in demand to in stimulus, increased stimulus to the brain, like this. In this, the frog leg was stimulated. There is increase in cerebral blood flow, which is accompanied by parallel increase in the cerebral metabolic rate for oxygen consumption and followed by decreased. And however, with higher doses of the volatile anesthetic agents, the cerebral blood flow keeps on increasing. However, the rate of increase or the proportion of increase in this may be significantly more as compared to the rise in the cerebral metabolic rate for oxygen consumption. So that means at higher doses, like around 2 mAg, they are likely to disrupt the flow metabolic coupling and resulting into higher blood flows. And now, having said the effect of these anesthetic agents on the volatiles on the cerebral physiology, let us try to put the picture, a clinical picture, correlate that how they affect the various neuroanesthesiological procedures, the craniotomies, because of the supratentorial tumors or the SAHs. So how they are going to affect the operative conditions, the recovery profile, the post-operative complications, and the other neurological complications associated with their use. So first of all, we come to halothane. Halothane is a potent cerebral vasodilator, though it is said that the increase in the cerebral blood flow is more in the cortical region than the subcortical region, but its use has been associated with increase in ICP along with the systemic hypotension and possibility of cerebral ischemia. This agent is no longer in clinical use, especially in the neuroanesthesia settings. Isoflurane in clinical doses of around 0.2 to 1 mAg, they are known to cause almost no or mild change in global cerebral blood flow. Wherever the effect on the ICP remains very minimal, especially if there is no midline shift or pre-existing cerebral edema. This agent is known to cause EEG suppression at around 2 mAg, and it has a probable cerebroprotective effect which has been studied in many animal experimental models and in vitro studies. However, the role is not clearly known, but whatever is, this anesthetic has been associated with good cerebroprotective effect. So as we say in normal craniotomies without any midline shift, there is no effect. This is a study wherein this is patients with severe traumatic brain injury and they were posted for subdural hematoma and they underwent the emergency craniotomy. This study is from Indian Center and it has been published last year, wherein they have compared the propofol infusion with less than 1 mAg of isoflurane. That is the dose of isoflurane which is not associated cause much of cerebral vasodilatation. However, they observed that propofol-based anesthesia had better brain relaxation, lower ICPs, along with better hemodynamics. But contrary to this, the isoflurane is being used. It's a new use of using isoflurane for ICU sedation in doses of 0.5 to 0.8 MAC. So in these cases, they haven't seen any clinically relevant rise in ICP in patients with subarachnoid hemorrhage, intracranial hemorrhage, or ischemic stroke if baseline ICP values are low or only moderately elevated. And they said that it maintains cerebral autoregulation perfectly up to 1.5 MAC. So next we come to the sevoflurane profile, wherein it has a very favorable cerebrovascular profile, and it's sometimes labeled as is almost the best anesthetic agent available for inhalational agent available for neuroanesthesia. So because the global cerebral blood flow remains almost unchanged at the clinically used doses, it's least vasodilating, and it maintains autoregulation. And the ICP profile, the halothane is considered to be most increasing the ICP the most, followed by desflurane, isoflurane, or sevoflurane. However, it has an epileptogenic potential that around 1.5 MAC causes pharmacological stimulation of ECOG, and this has been used as an agent for intraoperative electrocardiographic monitoring, hyperventilation, along with sevoflurane, which is known to produce some epileptogenic activity. So if we compare the effect of jugular venous bulb oxygen saturation, propofol anesthesia versus sevoflurane anesthesia. This is a study I would really like to highlight, that if we talk about the cerebral oxygenation and overall delivery of the cerebral substrate to the brain, we always tend to say that the intravenous agents are better than the volatile agents. However, in the settings of hyperventilation and in hypothermia settings, it is seen that the global this jugular venous oxygen saturation, that is the cerebral oxygen monitor, that the sevoflurane under slightly hypothermic conditions, this causes a more dip in the JVO2 during hypothermia, where lesser dip, less than 50. However, in propofol group, often the JVO2 decreased to less than 50. So that means it has a favorable oxygenation profile as compared to propofol. This is another study from India, and it is from PGI Chandigarh, wherein they have compared propofol and sevoflurane on oxygenation as well as interleukin 6 levels in patients undergoing surgery for traumatic brain injury. Here in these are the patients which have severe traumatic brain injury, and they have found similar results. That is, the jugular venous oximetry is equally preserved with both the anesthetic agents. Rather, it is slightly better at the in the sevoflurane group, because the interleukin levels were less raised with the sevoflurane group. So offering a kind of cerebroprotective role of sevoflurane in these patients. Now, next is the desflurane. This is a popular agent, and because of its rapid offset and onset, and that is very important in neuroanesthesia because it allows early neurological examination, and its profile is almost similar to isoflurane. However, the ICP increase is more prominent in dense isoflurane. This is what is anticipated. However, this has a very good profile for obese and overweight individuals, and this is the study by Bilotta et al., wherein they studied the early post-operative cognitive recovery and gas exchange patterns after balanced anesthesia, sevoflurane and desflurane in overweight and obese patients undergoing craniotomy. Wherein after craniotomy, they have seen that the dural tension and brain swelling in both the groups were equal. So sevoflurane and desflurane were treated at par in both the groups. However, the emergence time was significantly less in the desflurane group, and the early post-operative cognitive recovery was surely better in the desflurane group. So these findings suggest that desflurane in normal conditions may not produce that rise in intracranial pressure and may offer an advantage in obese individuals. And Now, this is another study from our institute wherein we compare the intraoperative brain conditions in supratentorial craniotomy, wherein sevoflurane with nitrous and the desflurane patients was compared. And here also we found that there is no difference in the brain swelling and ICP in either the group. So this is the another advantage of desflurane, wherein desflurane 0.3 MAC. It is generally assumed that for MEP amplitudes, the TY is the best option. However, there are studies wherein the low dose of the volatile anesthetic agents, they can be used for administering for getting the MEPs recorded. Around the non-halogenated agents, nitrous oxide has gone into disrepute for no big reasons, like it is said that it is a potent cerebral vasodilator and it increases ICP, wherein it's a very potent analgesic and sedative. And the disreputes associated with nitrous oxide were that it increased the perioperative cardiovascular complications, wherein by Enigma 1 and 2 trial, they said, no, it is not possible and it's not happening actually. And post-operative neurological deficits and expansion of air bubbles and increased post-operative nausea, vomiting. But I believe this 175-year-old anesthetic agents cannot go waste like that, because there are no much evidence supporting the clinical disadvantages of nitrous oxide. So this was the IHAS trial, wherein they did not see any neurological or neuropsychological deficits with nitrous. However, a small group, the patients which had temporary occlusion of cerebral vessels, they had some deficits which were not seen at 3 months post-operative. Xenon is the agent, possibly the next ideal volatile agents, because it has almost many befitting criteria, because it offers an excellent cardiovascular stability. MAP doesn't get down, it doesn't increase the cerebral blood flow, neither the intracranial pressure. So this is the drug which is most commonly popular right now in 12 European countries, and the most of the data comes from Italy and France. And there is not much to say right now for the clinical use of the Xenon, wherein anecdotal course reports and few studies are saying that Xenon works well. And also this one case report where it has been used for awake craniotomies. Having said that, Xenon may be a good neuroprotectant also, but there is a controversy regarding volatile anesthetic agents, whether they are neuroprotective or they are neurotoxic. So what we have in our hand is the data, which is experimental and which is in different models like traumatic brain injury, stroke. This was a meta-analysis wherein the volatiles have been used prior to the ischemia, during or after ischemia, and they are good quality studies which instate in that the neurological deficit can decrease from 5 to 35% with the use of volatile anesthetic agents, and this evidence comes from the good quality studies. However, the female animals or the animals with comorbidity, they don't have any they don't have the neuroprotective effect was not evident, which I think is required more in the patients with comorbidities, and the young males may not require that degree of neuroprotection because of good reserve. However, from bench to bedside in vitro models to animal studies to the clinical studies, we have progressively lesser data to support them right now, but definitely we should not stop our efforts to convert this research from bench to bedside. From the neurotoxicity point of view, the neurotoxicity has been defined because of the effect of anesthetic agents on apoptosis and on the synaptic pathways, which results in the neuronal fibrosis and sclerosis. But in the clinical scenario, we have the results of gas panda and MAST, where even there is no clinical anesthetic neurotoxicity associated on the young minds. With this, I will conclude my talk, and my take-home message would be that volatile anesthetic agents, they are important armamentarium of the neuroanesthesia, and with the brains which are lax and the brains with not much of edema and midline shift, they are the ideal agents because they have many other advantages to set in. However, we need more data for clinical data wherein the affected brains or the ischemic brains, how the balance trips we don't know, and the neurogenic toxicity and the protective effects of the anesthetic agents, especially the volatiles in the neurological injury, needs to be explored more. Thank you very much.
Thank you, Dr. Bindra. That was a superb presentation, complicated topic. The brain is always the focus of interest right now. And so I think the audience has learned a lot from you. At this point, Dr. Jayashree Nair to introduce our next speaker from the ASA, Dr. Girish Joshi, while he's putting up his slides. Go ahead, Dr. Jayashree.
Good evening. Greetings to all on the World Anesthesia Day, and welcome to all on the ICASA meeting being held today. And good morning to all our international guests and speakers. It's a great pleasure for me to introduce Dr. Greesh Joshi, who is, of course, well known in the USA, but is very well known in our country as well. All of us, I can confidently say, know him, and he's a friend of ours. He is at present, and has been there for a very long time, the professor of anesthesiology and pain management at the University of Texas in Dallas. He's also the attending anesthesiologist at the Parkland Hospital in Dallas. He received his medical degree, MBBS and MD from Pune in India. And then he went on to Ireland, where he did his FFARCS. He also went in the United States. He has received the MD from the university. He is also the diplomat of the American Board of Anesthesiology. Needless to say, he has several publications, and he has original articles, review articles, and several editorials in reputed journals. He is also the executive section editor for Anesthesia and Analgesia, and has been the past president of several societies: Society of Ambulatory Anesthesia, the SAMBA, Society of Anesthesia and Sleep Medicine, and the Texas Society of Anesthesiologists. He also serves on the board of directors of the Prospect, as we all know, and is a member of the procedure-specific pain management group, which is so important these days, and we all try and practice it here as well. So welcome, Dr. Girish, and it'll be a pleasure to hear you.
Thank you, Dr. Sood. And I want to thank the Indian College of Anaesthesiologists, as well as the American Society of Anesthesiologists, particularly Dr. Beverly Phillip, who invited me to speak. It's an honor. And as soon as I got the invitation, I was delighted to be able to participate. What I've been asked to do is talk on ideal inhalation agent. Do we have one? These are my conflicts of interest. I received honoraria from Baxter Pharmaceutical as well as Pacira Pharmaceuticals. What I hope to do is initially discuss the characteristics of an ideal inhalation anesthetic, and then more importantly, discuss how to optimize inhalation anesthesia with currently commonly used inhaled anesthetics, as well as then compare currently commonly used inhaled anesthetics. There's a laundry list of ideal inhaled anesthetic. As you can see, ideal inhaled anesthetic would be of high potency, low solubility in the blood as well as in tissues, and that would promote rapid equilibration as well as elimination of the inhaled anesthetic, thus a rapid recovery. This inhaled anesthetic would not have any deleterious organ function effects, either on the respiratory function, cardiovascular, GI, hepatotoxicity, nephrotoxicity, etc., as well as have no effects on immune function or developmental effects, and preferably would have some organ protection effects. Also, this inhaled anesthetic would not have any physical or metabolic degradation and thus could be used with low flows, would not cause any occupational exposure hazards, and no reaction to carbon dioxide absorbers or filters, tubings, etc. More importantly, it would lack any environmental impact, including during manufacturing, and finally, would have low acquisition costs. Obviously, we do not have such an inhalation anesthetic, and therefore, the currently commonly used inhaled anesthetics that include isoflurane, sevoflurane, desflurane, and nitrous oxide are the ones we're going to talk about. Each of them have their limitations and benefits. Nevertheless, we have to understand that to optimize their use, no matter what their benefits or limitations are, we need to know what potential complications can occur and how you can prevent them. It's well known that all inhaled anesthetics, in fact, all drugs we use in our balanced general anesthesia technique, whether it be midazolam or inhaled anesthetics, muscle laxants, propofol, all of them decrease ventilatory response to hypoxia and hypercarbia, and they also decrease airway patency. These effects occur at very low dose, which are clinically not relevant. In other words, 0.1 Mac of an inhaled anesthetic can cause these effects. So in the real world, 0.1 Mac is obviously less than Mac awake. So you could have an awake patient who could have decreased ventilatory response to hypoxia, hypercarbia, and decreased airway patency, so increased potential for airway obstruction in the recovery room and the post-operative period. Also, it has been realized that all drugs we use, including inhaled anesthetics, at very low dose can increase laryngopharyngeal dysfunction, which may increase post-op pulmonary complications, need for tracheal intubation, ICU admission, and obviously increase length of hospital stay. The reason for these complications is that the laryngopharyngeal dysfunction may increase microaspirations because the pharynx, when it contracts and the larynx should close, that normal function does not occur. Finally, deep anesthesia has been shown to increase delirium and cognitive dysfunction, which is relevant for our elderly patients. As I mentioned, we, in modern times, do not use a single agent to provide general anesthesia. We use what's well known as a balanced general anesthesia technique, where we use an inhaled anesthetics or another sedative hypnotic such as propofol, Tiva, to provide hypnosis and unconsciousness. We use muscle laxants for relaxation and opioids for antinociception. Because we don't use inhaled anesthetics in silos, we need to understand how these drugs interact. And thus, we need to basically use these drugs optimally. Thus, coming to inhalation anesthetics, we need to use minimal depth of anesthesia, as deep anesthesia can influence post-op outcome. More importantly, because each of the drugs we use intraoperatively can interact with each other, either synergistic or in additive effects, which we don't know exactly, we need to use minimal drug combinations and shortest acting drugs at the lowest possible dose. Also, as a part of a general anesthesia technique, we need to use at least 1 or 2 antiemetic prophylaxis, because several studies have shown, and this systematic review and meta-analysis of 14 randomized controlled trials showed that if you use at least 1 or 2 antiemetic prophylaxis, then the PONV incidence after inhalation anesthesia would be similar to that after Tiva. I'm not suggesting that you do not use Tiva in a high-risk population, high-risk PONV population. What I'm suggesting is that we should routinely use PONV prophylaxis for all our patients, particularly for inhalation anesthetic, no matter what their AFL score is. In fact, I would suggest that we should abandon the use of AFL score. Also, in an effort to decrease opioid effects, this is a paper which is going to be published in Anesthesiology, where we provide detailed discussion and evidence for use of opioid-sparing analgesia rather than opioid-free. As I mentioned, we need to use minimal drug combinations, and in an effort to use opioid-free, which has become an unfortunate fashion, at the detriment of our patients, people use ketamine, dexmedetomidine, magnesium infusions, and maybe causing more harm to our patients. All this adds up to the inhalation anesthesia complications. Also, we need to use the minimal concentrations of our inhaled anesthetic. Obviously, we're concerned about recall, and many times we provide deep anesthesia just because of our concerns of recall. It's now well recognized that to prevent recall, all we need is 0.8 to 1 MAC of no matter which inhaled anesthetic you're using. There are studies after studies confirming this effect. This is one of the studies that looked at desflurane concentrations to achieve adequate anesthesia based on a BIS of 45 to 60. There are several messages from this study. A, that the anesthetic requirements vary significantly between patients. However, even if you look at the outliers, the maximum concentration in the outliers required was about 1 MAC. It's a relatively older study in my mind, but let's look at a more recent study, again confirmed that younger patients obviously will require higher concentrations of inhaled anesthetic, but even in that population, the average requirement was about 0.8 MAC. More recent study published in JAMA in 2019, though the primary aim of the study was to look at BIS-guided approach versus standard of care approach to prevent dementia, post-op delirium. But if you look at the anesthetic concentrations used in the study, even in the so-called usual care, the amount of anesthetic required used was 0.8 MAC as an average. Thus, we can safely say that we can prevent recall in our patients if you use 0.8 to 1 MAC. By using lower concentrations, we would avoid the side effects of no matter which inhaled anesthetic we use. More importantly, we need to use low fresh gas flows because the benefits are well known. Unfortunately, despite of the knowledge of the benefits of low fresh gas flows, most of the world, people still use higher flows. Therefore, we now have a mechanical or automated approach to titrating inhalation anesthetic. This is one of the recent studies that looked at titration of inhaled anesthetic, automatic titration, and showed that low flows were used and it reduced the inhaled anesthetic use as well as saved costs. This would be beneficial with regards to the environmental effects of the inhaled anesthetics that are well described. Also, more recently, and there's a paper that was been published just a couple of months ago in Anesthesia Analgesia, where now we have ability to extract these inhaled anesthetics and collect them rather than dispose them into the environment. And thus, this will allay our anxiety regarding the environmental effects of our inhaled anesthetics. In fact, this particular study and the device in this study has now been approved by the FDA. We hope that in near future, we would have these FDA-approved devices that would collect the inhaled anesthetic and maybe we can reuse them. Thus, we would not be concerned about environmental effects of these drugs, and the environment concerns would basically be not relevant, so we would use appropriate drug with their appropriate benefits. Now let's compare the inhaled anesthetics, which we currently have. As I mentioned, the currently available inhaled anesthetics include nitrous oxide, isoflurane, desflurane, and sevoflurane in the order they were introduced for our clinical use. The benefits of each of these drugs have been already discussed. As I mentioned, the drug which we all want is the fastest acting or fastest onset drug with a rapid recovery. Once we have rapid recovery from the patients, from these inhaled anesthetics, obviously all those side effects, even with low concentrations, which I described earlier on, would be negated. The most fastest onset and offset drug we have is nitrous oxide. It's an age-old drug, well known. If you see its blood fat coefficient is only 2.3, significantly more than desflurane, which is the next fast offset drug. So how do we use these drugs? Unfortunately, though there are several benefits, well-known benefits of nitrous oxide, it provides excellent amnesia and analgesia, and thus it will decrease the inhaled anesthetic requirements as well as opioid requirements, both of which can cause hemodynamic instability, or their concentration would be decreased, and thus we would have hemodynamic stability. We have then rapid emergence from anesthesia. In fact, there are studies that have shown decreased persistent postoperative pain with the use of nitrous oxide because of its NMDA antagonist properties. Despite of all these well-known benefits, unfortunately, people do not use nitrous oxide for different excuses, that it might increase PONV, but we know that is not true. In fact, all recent large studies, the Enigma 2 study included, show that if you use at least 1 or 2 antiemetic prophylaxis, which is the standard of care, as I mentioned earlier on, there is no difference between PONV with nitrous oxide, without nitrous oxide. And if you are concerned of PONV and you do not use nitrous oxide, you end up using higher concentrations of inhaled anesthetics and opioids, both of which increase PONV. Thus, it does not make sense to avoid PONV, nitrous oxide, with the inappropriate concerns of PONV. Yes, nitrous oxide diffuses in the airfilled spaces, so it's not relevant to use it in middle ear surgery or eye surgery, but its effects on bowel expansion are clinically irrelevant, and thus it can be used in abdominal surgical procedure, including laparoscopic procedure. There is excellent review article from the European Society of Anaesthesiologists task force, which looked at every possible evidence regarding nitrous oxide. And what this group of authors concluded, that many perceived drawbacks of nitrous oxide, such as nausea, vomiting, used during laparoscopy, and even environmental effects, are exaggerated and misplaced. The problem is people who talk about environmental effects of nitrous oxide do not understand that the environmental effects of nitrous oxide are not the same as the environmental effects of other inhaled anesthetics, such as desflurane or sevoflurane. Nitrous oxide influences the ozone hole, as well as, in contrast, desflurane and sevoflurane have different effects. And thus, avoiding nitrous oxide, in fact, would be a disservice for our patients because of the several benefits of nitrous oxide. Now, coming to more modern anesthetic, DES and SEVO, as you can see from this slide, as I mentioned, each of them have their own benefits as well as downsides. Desflurane, no controversy, allows rapid and consistent emergence from anesthesia. One might argue that there are few minutes of differences between DES and SEVO. Does it really matter? That's up to personal use and personal practices, depending upon how fast turnovers you have, what type of practice you are in. Also, because of its rapid recovery, it is important that we do not titrate down desflurane as we would sevoflurane or propofol Tiva. If you do so, you would have a patient who rapidly wakes up and thus might have emergence delirium. It's not the drug, it's how we use the drug that matters. Obviously, the downside of desflurane is its pungency that can cause dose-dependent airway irritation and hyperdynamic response. And there are concerns about environmental effects of desflurane, which could be greater than that of sevoflurane. Hopefully, once we have these extraction devices that are FDA approved, extraction of inhaled anesthetic, and thus these environmental concerns may diminish or be avoided. Sevoflurane is one of the best drugs. In fact, I would say the only drug that is currently available to us for inhalation anesthetic. It does have slightly longer duration than desflurane, and thus we need to get a faster recovery. We need to titrate down sevoflurane. What this slide shows is the dose dependency of desflurane on a patient's airway responses, such as laryngospasm, bronchospasm, etc. At 2 MAC, 75% of patients would have these respiratory side effects. At 1.5 MAC, it's about 30%, and at 1 MAC, there is no difference. So thus, there is a dose-dependent effect of desflurane on the respiratory reactive airway. However, I would avoid desflurane in patients with reactive airway disease. Interestingly enough, recently, just last couple of years, there have been studies that have looked at DES and CO and the effects on analgesia as well as hypnotic effects. What these authors or investigators were attempting to do is, are all inhaled anesthetics similar? So they used equi-MAC values of DES and CO and assessed BIS monitoring and BIS values, as well as surgical pleth index, which is anti-nociceptive or nociceptive monitor, which provide some gauge of analgesia intraoperatively. And what they found was that the patients who had received DES had, for the same MAC value, had lower BIS values and had lower pleth index values. That means the analgesic effects were better. This is not to suggest that inhaled anesthetics have some analgesic effects. It's just that they observed less anti-nociception with desflurane. That was confirmed in another paper that was published in BJA. Again, similar study design and similar conclusions, that if GA is maintained with DES and CO at 1 MAC, same MAC values, the use of remifentanil use, in this case, they confirmed it not just with the pleth index values, but also the need for opioids intraoperatively. The remifentanil requirements were lower with DES and CO as compared to CO. We have no idea why there are these differences. We don't know. This is a new revelation, but something to look into. So to summarize, although we do not have an ideal inhalation anesthetic at present, the modern inhalation anesthetics are safe and effective if used appropriately. And I described to you the appropriate use of these drugs, whether it be nitrous oxide, sevoflurane, or desflurane. And for inhalation anesthetic, sevoflurane is the drug of choice. For maintenance of anesthesia, I cannot emphasize enough. It is time we get on board and start using nitrous oxide appropriately for our patients and not use excuses to avoid the use of nitrous oxide. The age-old discussions and education was wrong, so it's time we start educating our juniors in benefits of nitrous oxide. As far as differences between DES and CO are well known, and the use of these drugs are based on personal preference and biases, as well as personal clinical practices. Thank you for your attention.
Thank you, Dr. Joshi, for an outstanding presentation, bringing us back to nitrous oxide, one of the first inhalational agents besides ether that was introduced, very appropriate for this discussion today. I will share my screen now because we're going to go to the question and answer session. Let's see here. Okay, we have panelists that are going to be managing the questions. Do any of the panelists have any questions to ask the speakers?
Panelists, questions to speakers. Yes, I have a couple of questions, if I may ask.
Please
Shall I go ahead?
Yes.
The inhalational agent halothane has been almost discontinued. But this is not a question, this is a comment. But I think it has a place in the management of patients who have hyperdynamic ventricles. For example, we have hypertrophic cardiomyopathy, where if there's sympathetic stimulation, the LVOT will shut off. Similarly, in patients who have tetralogy of Fallot, if the infundibulum is stimulated, either exogenously or endogenous liberation of catecholamines, the right ventricular outflow tract will close. So in these patients, halothane has some place. That is my impression. That's a comment. Of course, Saikat can comment on that. My question to Saikat, I think there's one question to Saikat from the audience.
Just
about, yeah.
Go ahead.
That is about steel phenomenon with isoflurane. How is it reality, or what is it? Does it occur on the intraoperative settings?
So what we'll do is Dr. Sengupta first tell us, is halothane okay or preferred for the situation that Dr. Muralidhar brought about, and then tell us about the isoflurane vasodilation, coronary steel.
Yes, yes.
Yeah, okay. I think I would agree with Dr. Murali, sir, and say that I think halothane to be completely taken off was possibly not the best thing that happened. And it is now like a real challenge to find a vaporizer of halothane even in most in India.
Yes,
so I would agree with Murali, sir, on that. Regarding, I think, the coronary steel phenomena with isoflurane, it has been something that we used to read during our residency days, and then possibly it went out, and because it was kind of people did realize that it could cause coronary arterial vasodilatation, but to create a steel, it was more dependent upon the forward pressures. So if the coronary perfusion pressures were possibly maintained, then the botheration about the coronary steel does not really take place. And if the oxygen debt that is incurred, if it is taken care of by the perfusion pressures, and subsequently whether it essentially would depend upon the forward flow. So if the forward flow is maintained, I think then the coronary steel is no more clinically relevant. And this has been, I think, repeatedly proven by several studies.
Okay, thank you. Now let's go to Dr. James Phillip. Can you give us an example of advanced clinical techniques like single breath induction, closed circuit anesthesia, or something similar for us to see, sir?
Certainly.
We can have you share the screen if required.
Let me grab a screen share.
I'll stop sharing.
At the moment, I can't yet grab it. I think you still have control.
Okay, let me. Sanish, is my screen?
Yeah, and I think Dr. James can.
Okay, now you have.
All right. Can you see my screen?
Yes.
Yes, we can.
Yes?
Yes.
All right. So let me give an example of, we were talking about sevoflurane being the only drug we have for inhalation induction. One technique that we've done numerous cases with and published in the years past was the single breath induction with sevoflurane. So here I'm using Gasman again. And what I'm going to do is go from, we've got the vaporizer setting and the breathing circuit and the patient's alveoli, arterial blood, vessel-rich group, muscle, and fat. What I'm going to do is prime the circuit at the beginning with 3 minutes of no ventilation, but have the breathing circuit filled with anesthetic. So we're seeing that the sevoflurane level is about to be approximately 8%. The patient takes a gigantic single breath of 40 liters a minute for a tenth of a minute, which is a 4-liter vital capacity. And when the patient takes that breath, instantly the expired concentration is coming up very high. Now, the patient isn't asleep yet because the vessel-rich group at this point is only at 1/3 of a Mach or 1/2 a Mach. The dotted line is at 1 Mach here. So that what we're seeing is a patient whose end tidal concentration could fool people into thinking that they're fully anesthetized, but in fact won't be at that point of anesthesia for another minute or so. Once we get the vessel-rich group up to 1 Mach, it's an easy time to place an LMA, or 1.5 Mach would be a better point to place an LMA. And this would be one of those a place where you could use sevoflurane in an interesting manner that you might not have thought of. One other example of inhalation kinetics that one can look at through simulation might be looking at desflurane, where we're going to set the fresh gas flow to 1 liter a minute at the beginning of the case after we've intubated the trachea, and use the vaporizer not going up at 3 and 6 and 9% the way we normally would, but rather start with the vaporizer at 18%, because the low fresh gas flow is going to cause the inspired concentration to go up very slowly. So let's take the graph and put it over here so we can see what's happening. And this is 18% desflurane on the vaporizer, 1% fresh gas flow. And as we begin this anesthetic, what we see is over the first, and I'm going to pause it now at 1 to 3 minutes, the inspired has worked its way up to about 6%. And as time goes on, when the expired gets out to about 6%, it's a perfectly reasonable time to then turn our vaporizer down to 9% at the same fresh gas flow. And if we do this, we realize we've gotten a very nice anesthetic. And if we look at the cost of this anesthetic, we see that we've spent $3.57 to get $1 of drug into the patient's body, but we've done a very nice beginning of a desflurane anesthetic that we could then go on for hours and hours at this fresh gas flow, or go down to a fully closed circuit if we wanted at 0.25 liters a minute and run this anesthetic, turning up the vaporizer a little bit to maintain that constant depth of anesthesia. And for an hour, or 2 hours, we can be giving an incredibly economical anesthetic because we're running at this fresh gas flow. So those are a couple of examples, and thank you for asking.
Thank you. That was great. Now, there's some more questions here. What about the greenhouse effect of volatile agents and the environment? Does anybody want to take a shot at it while you stop screen sharing? Dr. Girish, do you want to take a stab at that?
Well, obviously, there is no question that inhalation anesthetics have a greenhouse effect. And also, desflurane might have more than sevoflurane. But what happens is that people forget that even in TIVA, if you use TIVA, propofol TIVA, there are some side effects or environmental effects of propofol TIVA. So are we going to abandon inhalation anesthetics completely and go on to TIVA? Obviously, it's unrealistic. In the US, 70% of all anesthetics are inhalation anesthetics. So we need to balance out appropriately and decrease the environmental effects. And that is by using very low flows, if possible, which is possible. It's just that we don't pay much attention to it. But now we have these automated anesthetics, anesthesia machines, or workstations, as you call it, which hopefully will allow us to do so. And if we have the FDA-approved devices, which I know are in the process of being marketed, then all these environmental effects are going to be not relevant. But yes, there is environmental effects.
Yes, there was a question about sevoflurane-induced emergence agitation in PEDS patients, which was not discussed as a drawback. Anything
Oh,
else
is it for me?
Yeah.
Well, see, that's the I have not done pediatric anesthesia for the last 30 years. And Kumar, you probably are the best person to answer that. I don't speak on anything which I don't practice clinically. Yes, there is, again, theoretically I do know, but I didn't include that in because I don't practice pediatric. There are studies or case reports of increased epileptic effects of SIVO, but please answer that. You are the best expert for this.
Well, there's no doubt that there is a significant proportion of patients, children, especially during short anesthetics, will have emergence agitation, and that's seen commonly, not only with SIVO, you'll also see it with desflurane. It's less common with isoflurane, obviously, because of the delayed recovery. So that's an issue that has to be handled appropriately during the care of these patients. Let's go to another question. Nitrous oxide increases gut distension. Does anybody want to take a stab at that one?
Oh, I don't mind that. I mean, I would just recommend people to read that review article, which is from the European Society of Anesthesiologists, where they have gone into details of the study. There's no question that nitrous oxide does increase cause gut distension, and therefore should not be used in patients who have obstruction, GI obstruction. But for regular elective surgical procedure, even laparoscopic procedure, all the studies have shown that the surgeons have the increase in gut distension or cause of that is not clinically relevant. The surgeons do not appreciate any increase. More importantly, what I don't understand, which is an age-old thing which is going on since my residency days, where I was told, don't use nitrous oxide, even in there was no laparoscopy in those days, open surgical procedures, which I don't understand. Surgeons can move the gut around anytime, so overall, all these are excuses which we've been taught from theoretical backgrounds. And it's time that we educators tell our residents that it's okay. The evidence does not show increased problems with gut infection. And it is our fault that because we keep educating our people based on theory. Yes, theoretically, there could be increased ICP, but nitrous oxide is excellent for neurosurgery as well, for rapid recovery. So it's time we stop looking at theory and start looking at real outcomes.
Okay, Dr.
Let me
Bindra.
add to that a little bit, if I may.
Yeah.
When we look at the distension, or not the distension, we'll just call it the increase in volume. The increase in volume at 50% nitrous oxide, gas compartments will double their size. Once we get up to 75% or 80%, then it doesn't double anymore. It quadruples or pentuples. It's a mathematical measurable effect. So 50% simply doubles the size of compartments. And if the compartment starts small, it's only double that small size.
Thank you, James. And actually, that helps me to, again, remind the listeners that in the US, we use 50% nitrous oxide, not 70%. So all these comments are based on 50%. Thanks for that comment.
Dr. Bindra, question for you. What's the ideal maintenance agent for craniotomies, and how do you monitor the brain if we are using inhalational agents?
Oh, well, the ideal agent for craniotomy possibly maybe depends upon the type of brain you have. If I talk in particular, Like if your patient has a intracranial space occupying lesion, but there is no cerebral edema or massive, or you believe that autoregulation is intact, then the volatile anesthetic offer an excellent intraoperative intraoperative advantages. And we often use sevoflurane, and even we are used to using nitrous oxide 50%, 50 to 70% we use nitrous oxide. So kind of balanced anesthesia approach along with the opioid anesthesia. Volatiles for normal brain with normal autoregulation play they are good enough. However, in cases wherein there is a good cerebral tension, or there is an wherein you expect that the autoregulatory curves, especially in case of cerebral edema, massive intracranial brain bulge, or in midline shift, like in patients with severe traumatic brain injuries or large tumors, maybe TIVA becomes a better option.
Okay. How about monitoring? Do you believe in NIRS monitoring for the brain when you're using it for non-craniotomies?
Monitoring brain in non-craniotomy patients.
Yeah, like do you use NIRS, like infrared
Right,
spectrum?
we do, but however, the role of near-infrared spectroscopy is not very prevalent, and not many institutes have NIRS, but we do have NIRS, and we use in patients with carotid endarterectomies and in endovascular procedures. And the most common monitor which we used for intraoperative monitoring is BIS monitor, which tells about the anesthetic depth, and wherein and the NIRS is the another monitor. However, possibly its role in all type of routine craniotomies cannot be justified, and specifically in patients where you are think that they're prone to ischemia, like patients with carotid endarterectomies, possibly NIRS has a good role. And NRIS is mostly used for monitoring the brain and the spinal cord in cardiac surgeries, in bypass surgeries. So the most common monitor which we use intraoperative in routine craniotomies remains the BIS monitoring, along with the sometimes we go for transcranial Doppler monitoring in aneurysm surgery. So it depends upon the type of surgery you are going for.
Thank you. Thank you. Now, this is a question for everybody on the panel. Since we're talking about BIS, can the end-tidal anesthetic concentration be used as a depth of anesthesia monitor?
Yeah.
Yeah.
No, Murli, please go ahead. No, please go ahead.
No, I had a related question. It's a related question to the same question. But when you mentioned about MAC 0.8 is sufficient to prevent awareness, you were referring to end-tidal concentration, I guess.
Absolutely, yes.
Yes, it's end-tidal. What we have observed is the depth for a given depth of anesthesia. If the patient, you mentioned about influence of age, we have reported that with the decreasing temperature, the amount of agent needed to maintain a particular value of BIS also comes down. Suppose patient temperature falls from 37 to 36.5 or 36 or 36, 35.5. For each degree drop, there's a decrease in the anesthetic dose required by a mathematical factor of about 0.13%. That's what our observation. We have publishing that result. That is my comment. And the question about BIS monitor, what is the question, sir? Dr.
Question is, if you just look at the end-tidal concentration, can you ensure that there is adequate anesthetic effect? That means it's a depth of anesthesia monitor by itself.
Yeah, that's a great question. See, if you have BIS, nothing like it. If you don't have BIS, we have to go by the end-tidal anesthetic agent concentration. And also, as Girish has pointed out, you have to take care of the age factor and, as I said, the temperature factor. Depending on that, you can only make a guess of the depth of anesthesia. But if you want something more concrete, BIS comes somewhere close to that, but it does not answer all the issues associated with monitoring the depth of anesthetic. That will be my response.
I think that's correct. You cannot rely on the end tidal sensation to ensure depth of anesthesia and awareness. You cannot totally rely on it. We don't have a perfect monitor for that. And I think most of the panelists will agree. And we have another 30 seconds before we go to Dr. Baljit Singh.
Yes.
Okay, Dr. Baljit Singh, time for you to give us the vote of thanks.
The end tidal is not the brain. Recognize that the end tidal leads the brain by about 3 or 4 minutes, and therefore quick changes in end tidal will not appear on the brain.
Right. I agree.
Thank you. I think it's about time, so we'll have Dr. Baljit Singh give us the vote of thanks, and thank you to everybody.
Thank you, Dr. Belani. Today is the day when history was written in 1846, and that was the past. And today is also the day when American Society of Anaesthesiologists and Indian College of Anaesthesiologists came on a common platform, and this is a history in the making. For making this happen, I would first of all like to thank the President of American Society of Anaesthesiologists, Ms. Beverly Phillip. Her opening remarks on leadership and professional development as a way forward carry a lot of significance in today's world. Besides that, she laid a lot of emphasis on quality development, whether it's for teaching and training and research. And I'm sure with the growing association between ICA and American Society of Anaesthesiologists, we together can forge a relationship of shared values and collective growth. Dr. Belani, as overseas honorary dean of ICA, is a very strong link that ICA has beyond the seas. It is largely due to his efforts, along with his team, that ICA footprints are visible at the international level. Thank you, Dr. Belani. And your role is very valuable. On behalf of ICA, I express my deep gratitude to you. Dr. James Phillips, as described by Dr. Belani as a man behind the Gasman software program that he has built for inhalation agents, there couldn't have been a better speaker than him for evolution from ether to xenon. It's my strong feeling that the Gasman program has made administration of inhalation anesthetic agents a lot safer. Thank you, Dr. Phillips. Dr. Saikat Sengupta, Dr. Ashish Bindra, and Dr. Girish Joshi are the kind of names we often come across in the scientific arena. Their excellent talks, doing full justice to the assigned topics, carry a lot of scientific value and sure would stimulate research, particularly for younger members. Thank you, Dr. Sengupta, Dr. Bindra, and Dr. Joshi. Dr. B. Radhakrishnan, the president of ICA, is a fountainhead of academic growth that ICA has witnessed in the last few years. Whenever I have discussed any issue with him regarding ICA, he would always come up with an out-of-box solution that I found very, very practical. My contemporary in ICA as the CEO, Dr. Jayashree Sood, is an excellent organizer of scientific events, and the international conference she organized last year speaks volumes of her abilities. Besides that, she's a much admired and loved teacher by her students. Dr. Kanchi Muralidhar, whom I have known since 1980, is a brilliant teacher and a keen researcher, a master of his trade, cardiac anesthesia. He is frequently seen speaker at many scientific events in India and overseas. Beyond anesthesia, he is an excellent exponent of classical music that many of you probably would not know. As a dean of ICA, he has started many programs in various centers all over the country. The success of any scientific program that is organized is basically the connect between the audience and the speakers. That is reflected by the active involvement of the audience that we witnessed from the chats and the discussion we had after the talks. On behalf of ICA, I thank you very much for your active participation. There are many hands and minds that go into making any program seamless and successful. Dr. Sanish is one such person who, though works behind the scene, is always at the forefront of scientific programs that ICA has organized. Thank you, Dr. Sanish. And for want of a better word, I would like to thank everyone associated with the organization of today's program, which is the first of its kind, and I do hope it paves the way for a lot more to come in future. Thank you, one and all.